Greetings, teammates. This is I'm Dr. B, and this is my teammate Nate, no longer a victim. We just sanitized our hands. As we mentioned before, we're not wearing masks. I now have both shots, and he's had it, so he's got the antibodies. Today we are doing a video of the soft tissue assessment of the hip and pelvis. In this situation, Hoppenfield says to strip all the way down. We won't in this course, but it would be important for you to be in Spanx, or what are they called? Spandex, so that before COVID, I would have my students dress down as far as you feel comfortable. Preferably something tight to the skin and exposing as much skin as possible, and yet so that you are comfortable. So having done that, I'm going to have Nate, please, if you would, strip down. Of course, we're doing the visual inspection here. I'm looking for fluidity, symmetry, posture, proportion, color, contour, condition, creases. And with the fluidity, how he's moving, do you have any hip or pelvis or low back pain in the process? And my eyes didn't pick anything up there, and he denies anything, so I'm going to move on from that point. If you would please, we're going to do an assessment of the soft tissues of the hip and pelvis. Obviously, this can get personal. You stop me before it gets personal. You have all the power here, okay? I'm asking your permission to touch the muscles and the ligaments and the soft tissue around the hip and pelvis. There's no need for me to touch any privates, but I may get close. You stop me if getting close makes you uncomfortable, okay? We would obviously have a witness when we are assessing around the pelvis, so always have a witness with you. If you would please, lay down on your back. This would be, of course, supine. The soft tissues of the pelvis, we divide the body. Hoppenfield has divided the body into 5 regions. We have the femoral triangle, we have the greater trochanter, we have the sciatic nerve area, the iliac crest, and then major muscles of the pelvis. We're going to start with the femoral triangle. To make this accessible, if you would please, we're going to say that this right hip is the involved side. So with your permission, may I hike your shirt up a little bit? And that's fine right there. Very well. Please move this ankle across this knee. Now here I'm looking for hip flexion, hip abduction A24, and external rotation. Truly, that's what he's doing, and I'm looking for fluidity of movement, but I'm not assessing his range of motion yet. This just makes the soft tissue stand out. The femoral triangle, and please follow along with the different figures under soft tissue in Hoppenfield. There's a spot or two I disagree with Hoppenfield, and some of the books we need to make some changes in. Femoral triangle runs from the ASIS down to the pubic symphysis. So with your permission, I'm going to run my fingers down to here, and I'm going to come to a bony area before we get to the privates, right there, okay? The inguinal ligament is the superior border. It's a triangle. The sartorius muscle, longest muscle of the body, runs from the ASIS, anterior and oblique, descending across the thigh, and attaches down in the knee what we call the pes anserine, which means goose's foot. 3 toes. 3 muscle tendons come together there on the anteromedial, just distal to the flare of the tibia. We'll study that more with the knee. The medial border is the adductor longus, and then we will identify other soft tissues, but those are the borders. Inguinal ligament, sartorius, and adductor longus. We're going to start with the inguinal ligament, which you can put the heel of your hand here and angle down towards the already established. I noted it's right here, so I can go right to it. I'm on the superior rim. This is also a first aid technique. If someone is bleeding out in the lower extremity, this is a pressure point where you can hacksaw right through and cut off the blood from the femoral artery and potentially save a life. Anyway, with soft tissue palpation, let me have you bring your leg up a little bit. It makes things stand out. Now, because his abdominals tie on distally to the inguinal ligament, relax, there I would, and go ahead and let the leg flop, there you go. There I could feel it. It's subtle unless he pulls it up and uses his abdominals for an isometric and makes it stand out. And I'm just palpating its length from the ASIS to the pubic symphysis. Having done that, I'm going to go right to the middle of it and split the difference. Step off just distal and relax your leg. There you go. I might actually put it into a passive position because this is stretching the muscles and making them taut. So here, there. Right there I can feel not the vessel, but I can feel the pulse in the femoral artery. Just lateral to that, but you cannot feel it, can't isolate it, is the femoral nerve. Medial to the pulse of the femoral artery is the femoral vein. Again, you're not able to palpate it. The way I remember these is the word navigate. We're going to navigate the femoral triangle. Lateral to medial, nerve, artery, vein. Navigate. Looking to elicit tenderness, even though I can't feel the nerve or the vein, but the pulse I can. Unique that this major artery is so subcutaneous. This is where we access to do angiograms and angioplasties and do a number of things to the abdominal and ascending, descending aorta, etc. Also, along the inguinal ligament and just distal down in. Okay, just probe around. There are a large bundle of lymph nodes there. Of course, if there's no infection in the lower extremity, you're not going to feel anything. But if there is an infection, one, you can probably anticipate it with some kind of wound or seeing other symptoms in the extremity, stepping off the inguinal ligament and travel down an inch or two, depending on the size of the person's bony system. You can feel, boy, a real strong pulse there, but feel slippery grapes. Usually you shouldn't feel anything. Now we're going to go to the lateral border. The sartorius crosses anterior to a medial lateral axis at the hip. So it is a hip flexor. It also goes oblique across the thigh and attaches down on the proximal anteromedial aspect of the tibia. As such, it crosses behind a medial lateral axis at the knee, so it is a knee flexor, and it is also a hip external rotator, because as the muscle pulls, this is actually the muscle that is primarily responsible to put your foot up over your knee, because it hip flexes, externally rotates the hip, and flexes the knee. Having done that, please push against my hand right here. Harder. Good. That makes that very muscle stand out. So from the ASIS, I'm going to palpate its origin coming right off the inferior edge of the ASIS. And you can palpate it because it is superficial. Push against my hand, please. It is superficial. Note my body mechanics. I've softened my knees, lowered my center of gravity. Some of you tall people might have to bend over. Don't. Bring yourself down to them. So, palpating down, any tenderness, down to its attachment, and we'll study that further with the knee. That's the medial border. The lateral border. Medial border, please adduct your leg by bringing the thigh across your midline, the middle. With this, it makes the adductor longus jump out. You are close to the groin. So reaffirm that I should only be on this muscle. It's doing an isometric, and you can follow it right up. That's the medial border. And we've done the superior border, making our triangle. We've done the femoral nerve, artery, and vein, lymph nodes. Relax. Let's keep the foot back over here, though, but I'm going to take the pressure off. The floor of this is consists of the primary floor is the iliopsoas or the psoas major. From inside the rim of the ilium, large muscle group comes down and attaches on the lesser tubercle of the femur. Primary hip flexor. Hoppenfield teaches that this is not palpable. But as an athletic trainer, we're taught that we can palpate it. In fact, you can palpate clear down in to the abdominal aorta and the anterior aspect of the lumbar vertebrae. We're not going to pursue that at this level. Just palpate the floor, looking to elicit tenderness. The floor is made up of the adductor longus, as well as making the medial border, the iliopsoas, and the pectineus muscle, which is later identified on the adductors and hip flexors. The femoral triangle. Also deep to the iliopsoas is the iliofemoral ligament, which is an athletic trainer we can put pressure on because it's deep to the iliopsoas. At this level, we're not going to pursue that. So the floor again is made up of the iliopsoas, pectineus, adductor longus, and we have the ligament of Bigelow or the Y ligament or the iliofemoral ligament. Just thickenings of the acetabular diarthrodial capsule. That completes the femoral triangle. Now we're going to go to the greater trochanter. If you would please roll towards me and face me. Thank you. We've learned how to orient with our bony palpation. We're going to do the same thing, and of course my client here is educated, so he assumes naturally the position, and truly that is more comfortable anyway. We're going to orient from the iliac crest, the ASIS and the PSIS, and then at the most superior part should be the greater trochanter. Again, when we found it before, because we've got the gluteus medius tying on to the anterolateral proximal aspect and tensor fascia lata and iliotibial band coming across, it's hard to find in the front, so we'll go and hook it from behind, and there is the greater trochanter. As far as soft tissues, on the proximal aspect of the greater trochanter, we have the gluteus medius tying in, but that we actually cover in another area, another muscle group. Right on the trochanter, you shouldn't feel anything unless it's pathologic. Just like the olecranon bursa, we have the trochanteric bursa. On occasion, you may get complaints of pain right there. With some athletic events or a lot of climbing with high stepping, the tensor fascia lata becoming the iliotibial band will get so that it slides back and forth over the greater trochanter. And as the person comes to a hip extension and a knee extension, it'll snap across the front, and it'll actually become an audible, and you can sense that snap. Boy, I've got a snap in my hip when I'm coming up with my hip. Classic for snapping hip syndrome. And that iliotibial band is snapping back and forth over the trochanter, and it irritates that trochanteric bursa. So right now I feel nothing there, but I could feel boggy if it was pathologic, or tenderness when we come back to those muscles. From here, the next location is we have learned how to find the ischial tuberosity, the butt bone, splitting the difference between the greater trochanter and the coccyx down in the gluteal fold. We're going to push in and up. Right there, I'm on the ischial tuberosity. Splitting the difference from the ischial tuberosity and the greater trochanter, you split the difference to right in the middle. This is a lot of glutes now. Deep in the glutes is the sciatic nerve. We don't feel it. There's not a structure you can palpate. But if it's pathologic, it will give us radicular pain. In addition to ridiculous pain, radicular, which means neuro-oriented. They'll complain of ache, tingling, numb, dead, sharp. But mostly when you're pushing on it here, the sciatic nerve is passing through the piriformis muscle. And if it is tender there and giving you radiating pain or symptoms down the leg, we call it sciatica. It may be one of three reasons. One is direct trauma to the buttocks, coming off of your inner tube and landing on the hard ice, or a herniation of some of the nerve roots, be it lumbar or sacral plexus, come together, bundle up, and make the sciatic nerve to feed the lower extremity, anterior and posterior aspects. Or it may be piriformis syndrome. The piriformis muscle, the sciatic nerve actually passes right through it. Perhaps you do come off of the tube or land hard on the glutes, not on the tailbone, but the body of the glutes, and traumatize those muscles. If the area is upset, the muscles, oh, we gotta protect, we're hurt. And the only thing the piriformis knows how to do is to contract, so it clamps down on that muscle. There are some tests we'll do later to determine if it is piriformis syndrome or not. Otherwise, we want to determine if it's herniated disc, piriformis, or a direct blow. So, femoral triangle, greater trochanter, sciatic nerve. Now I'm going to have you lean back to this point, iliac crest. There are cluneal nerves, C-L-U-N-E-A-L nerves, often affected if we're doing a skin graft from a large cutaneous area, epithelium, from the from the PSIS. I found it immediately, but it would be, here you can see the two dimples right there, up over the iliac crest, and the superior aspect of the iliac crest is subcutaneous. I'm right on it. Just inside, we've got lumbar fascia and other soft tissues originating, tying in. Immediately stepping off, we have the gluteus medius and minimus. But right on the superolateral edge, there are a number of nerves that pass over that are responsible for sensation in this area. Cluneal nerves. Personally, and it comes over to the widest part, ASIS, iliac trochanter. That's not right. Help me out, teammate.
The tuberosity of the ilium?
The widest part, and it's flat and triangular. I hate it when I do this on film, but I've gone blank. Anyway, the cluneal nerves pass over there. Hoppenfield says that you can at times palpate them. In my experience, I've never been able to distinguish a nerve coming over the edge, but you're going to palpate that. That's the fourth region. The fifth region is major muscles of the hip. Again, femoral triangle, greater trochanter, sciatic nerve, iliac crest, and now the major muscles. If you'd roll back to your back, please. We're going to do these by muscle groups, anterior or flexors of the hip, medial adductors A44, lateral abductors A24, and finally hip extensors. With the flexors, we have three primary flexors, one of which is the sartorius, which we've already isolated and taken down coming off the ASIS. We also have the rectus femoris, the most anterior and midline of the quadriceps, the only one of the four, as per quadriceps, four heads, that actually crosses the hip, so it's a two-joint muscle. We'll discuss the distal end when we come to the knee. It actually, Hoppenfield says it's not easy to find. You can, from the ASIS, it actually comes off of the anterior inferior iliac spine. So let me have you roll that way a little bit towards the camera. Thank you. There's a wrestling hold, but we'll keep you here. Okay, you can relax. From the ASIS, if you step lateral, you get another major muscle belly. That is the tensor fascia lata, or the tensor fascia lata. Got to put the emphasis on the right syllable. Got to get a little grin out of you people. Again, Boyer with his stupid dad jokes. Just between the two, the ASIS, step lateral and inferior. And you can actually feel a little soft spot in between the two. If I have you come back now and bring your knee straight up, it will make that rectus femoris become taut and you can find the origin. Having done that, relax. And now I can palpate just down mid-thigh. It is bundled in the fascia of all the quads, so you can't take it like the mobile wad of 3 and isolate it, but you're going to palpate down the midline of the thigh. And the other one is the iliopsoas, which Hoppenfield says we can't feel. We're not going to do it in this class, but you can actually get the person relaxed enough, but it takes a little bit to palpate inferior off of the inguinal ligament and deep into the iliopsoas. These are the hip flexors. Now we're going to go to the hip adductors. I disagree with Hoppenfield here. He says the adductor longus, if you would please, have the person do an isometric adduction. Pull your leg across. And the first one you come to that's really tight is the adductor longus. It makes it stand out better. Relax, please. If we're here, now bring the knee in, almost like you did the sartorius. Sartorius is also a hip flexor, so I'm going to resist here, push up against my hand, isolates that sartorius. Pull in against my hand, isolates and relax, the adductor longus, right up to the pubic symphysis. Hoppenfield notes that it's the medial-most muscle on the medial thigh. I disagree. I feel that the gracilis is the most subcutaneous, it's closest to the skin, and medial-most muscle of the thigh. It's another one of the 3 that will tie in to the pes anserine group. Can't isolate it, but it's one of the 5 adductors. We can isolate the adductor longus, then as a group, and truly I'm on one of the semimembranosus and semitendinosus hamstrings if you go too far back. But down the mid-thigh, we also have adductor magnus, adductor brevis, gracilis, and pectineus. Pectineus can be located from the ischial tuberosity deep between the sartorius and the adductor longus, right in here. That's typically the muscle when you say I pulled a groin, because it serves as it's a weaker of the adductors, but it's a hip flexor. And when you're swinging through swing phase, it's often the pectineus that you're going to pull. And if you palpate pain right there and get pain with hip flexion and adduction, you've isolated it. Relax. So the adductors, we did the flexors, the adductors, 5 of them. Now we're going to go to the abductors. If you'd roll towards me, please. Of course, this is a different leg. Straighten this leg out. I'm going to bend this knee a little bit. And from the iliac crest, fine specimen here, you step just off the iliac crest down to the greater trochanter. This is all gluteus medius and minimus. They are pure hip abductors because they are the lateral most muscle group, lateral of an anterior posterior axis. So they have the mechanical advantage. Please bring your knees straight up into the air, right there. When you do that, it puts them in an isometric, and you can palpate from the greater trochanter, which disappeared, there it is. So it triangulates out like this, the gluteus medius. If that muscle is weak, palpating all of the aspects and relax. If that muscle is weak, the person will demonstrate a lateral lurch or a gluteus medius lurch or a gluteus medius weakness, which we'll talk about with special tests. There is a special test for the hip flexor, the psoas major iliopsoas, called Thompson test. But that will test for range of motion and tightness or pathology, but we'll come back to it later. So the abductors, you've done the 2 of them. Now finally, posteriorly, if you'd roll on over toward me, please. Let me have you come way over to me for the sake of the video. The person would normally be just plain prone. You comfortable there? Okay. With your permission, I'm going to be touching down to your tailbone. We have a thumbs up. Relaxed. I disagree with Hoppenfield here. Hoppenfield says that the inferior border goes from the greater trochanter down to the ischial tuberosity. Well, that doesn't even cross the hip, because it's going from, it's actually a parallelogram that runs like this. No, he was saying from the coccyx, the tailbone, down to the ischial tuberosity. Okay? So that's the inferior border. No, it runs along the spine of the sacrum, and then that's the medialmost border. Lots of attachments in here. From the sacrum, clear down the greater trochanter, move posterior on the femur, there is the linea aspera. And it ties onto that ridge on the posterior femur for a little ways down. So the border runs clear down here. Not just from the coccyx to the ischial tuberosity, it actually comes clear down in here like this, the inferior border. The superior border parallels it from up by the PSIS, clear down to the superior aspect of the ischial, of the femoral greater trochanter. So these muscles are paralleled this way, and then the borders are paralleled this way. Let me have you lean up on your right side. So the borders will parallel from here to here, and like this, and then the medial and lateral border are here. These muscles pull this way. Being posterior to a medial lateral axis on your belly, please. That makes them, bend your knee a little bit. Now bring your thigh up off the table. That is a hip extensor, because they pull like this and bring it away from anatomic position around a medial lateral axis. Because the fibers pull like this, since a muscle can only pull and cannot push, it will also do hip external rotation. Now the reference is the anterior thigh coming off this way. So when he goes like this, it is pointing externally. So that's external rotation, even though it's the foot that's going in. That's not medial. That's not the reference. The reference is the anterior thigh turning externally. So it crosses posterior to a vertical or superior inferior axis, makes it a primary hip external rotator. Being posterior to a medial lateral axis makes it a primary hip extensor. Those are the major muscles of the hip and pelvis. We did femoral triangle, we did greater trochanter, sciatic nerve, iliac crest, and then major muscles. Major muscles is 4 groups: the flexors, anterior, adductors, A44, medial, abductors, A244, lateral, and extensors, posterior. Thank you for your time. I hope I haven't led you astray too much. Anyway, good luck to you, and lots of mileage, lots of repetition. You already know the anatomy, so just rehearse what exit comes next on your rubric, and then you can rehearse actually doing what you need to do to make those structures stand out. Good luck.